just sort of joystick them to get this alignment. You have to check it on the C arm and then pass the KVR. Once you have passed one of the KVRs straight, then you actually see the range of motion. If you have reasonably good range of motion, you are practically aligned that intra-articular fragment well. How do you see lateral view? Yeah, so what we do is we keep a patient on the lateral position and we keep the hand on the posterior. So the C arm is from posterior to anterior, and you just check when you are taking the lateral view, you hold the humerus like this and take it. So you always do this. You don't try to push this upwards. Then there is always, that's what we do for the supracondylar fracture as well. You can take a, that is better, of course. That is always better. If you rotate a C arm, it's always better. That's called shoot through X-rays. It's always better. Yes.
Thank you.
Thank you very much. Thank you, Chairman, sir.
Have a safe journey back home.
Thank you.
Thank you. Dr. Sanjay Devan. He will be presenting on management of late supracondylar fractures in children.
Good morning to dear friends and seniors. I'm sorry for my bad voice. Supracondylar fractures, they are the commonest fracture around the elbow in children. They are classified in type 1 is undisplaced, type 2 is hinged fracture where you have a posterior cortex intact, and type 3 is completely displaced. Now the management of these three is, type 1 is treated conservatively, type 2 you can treat both conservatively and operatively, and type 3 again you can treat conservatively, but most of them are better treated with operative, either open or close. Now supracondylar treatment in type 3 fracture, you can treat them by fixing with K-wires. So there are different ways of fixing them. Out of these, the fixation from both the side, one medial and lateral wire, gives you a better stability. But you can fix, if you are scared of the L and nerve, you can fix it from lateral side, 2 wires. So the operative trick, the points which you need to remember, that image is to be moved from AP to lateral. Always prefer this way. If you try to rotate the elbow and see the lateral view, many a time the reduction, if you feel in the AP is good, but if you turn it, you lose the reduction. So it is always better to see the lateral view by turning the C arm. Now, you need to see few points. You take a Jones view, you all are aware of that, and in Jones view you measure the Bowman's angle and see the medial and lateral pillar. Now Bowman's angle, if there is a basic rule, if there is a change of 5 degree in Bowman's angle, that accounts for a final change of a carrying angle of 2 degree. So any 5 degree change will result in 2 degree change of final carrying angle at the adult age. So this is, we used to use a Bowman's angle. This is type, this is A. You have a pointer? Yeah. If you see this there, if you draw a line in the axis, this is line A, then epicondylar axis, and then you draw and then your line, this is line C is drawn from the lateral epiphysis. Now this angle is A, which you used to call a Bowman's angle initially. This was previously we used to Bowman's angle. Now we calculate Bowman's angle with this angle. Now this angle is measured from 64 to 81 degree, an average of 72 degree. So if this angle exceeds the 81 degree, now this angle, if you see, this angle is more than 81 degree, then you develop a coxa vara. So you have to keep this angle below 81 degree. To don't get, if you keep it below 81 degree, then you will not get the coxa vara finally. Now, you have to see the crescent sign. Crescent sign, if you have a lateral tilt, you have an overlap of epicondyle lateral epiphysis in the ulna, and if you find this sign is there, that means you have something bad with your reduction. You need to check your reduction and go back and reduce it again. Then you have a lateral, in the lateral view again you see the fishtail sign. If you see this beak, if this beak is there, this again speaks of that there is a loss of reduction, and you again go back and see your redo your reduction. So three things you have to see: the Bowman's angle and lateral pillars, fishtail sign and the crescent sign. Now in supracondylar fractures we cannot accept, this reduction is not bad for supracondylar fracture. You have to have a absolutely correct, because reduction, if you don't have, then you are leading to a problem in the future. Now, the late presenting supracondylar fracture, if you go by the literature, in literature you find if the fracture is more than 2 days old, it is called late supracondylar fracture. Though it is a very common feature, most of the time you get supracondylar fractures which are 2 days old. The problems of these late presenting supracondylar fractures are that they are uniting fracture, so close reduction is difficult, and there is high incidence of stiffness, neurological and vascular complications, particularly after repeated manipulations, then chances of myositis ossificans and hazards of malunion and further need of a recorrective surgery. If you go by literature, Yen et al., he stated that if the fracture is greater than 1 week old, there is usually sufficient callus formation to make close reduction extremely difficult. In these cases, we advocate open reduction. Then again, Etting et al., the healing of metaphysis is faster in children, so presence of soft tissue callus by the end of first week renders the fracture irreducible. Rasool stated that open reduction and internal fixation should be preferred after swelling has subsided, but not later than 5 days after injury, since possibility of myositis ossificans increases after that. Kapoor et al. Stated that attempting close reduction under general anesthesia is justified in cases presenting as late as a week before restoring open reduction. So gradually we developed a tendency that we can try some close reduction. But the usual consensus for these late presenting supracondylar fracture is to do open reduction in cases more than 7 days. Now so the treatment modalities for these late presenting supracondylar fracture can be open reduction and pin fixation, which is the currently best method and preferred method. Alternatively, you can leave them. There are advocates who say that you leave these fractures to malunite and then correct after in a later date with osteotomy. Now, problems of leaving this fracture to malunite is that you get develop a deformity, there is a stiffness and restriction of movement, long follow-up with vigorous physiotherapy, and you have to wait for a fracture to remodel, increased deformity. This deformity keeps on increasing as the time passes. Secondly, even if you correct these deformities, you see the deformity is corrected, but you still have a hump, which is an ugly hump, which doesn't look good. So possible complications of open reduction here can be infection, vascular injury, myositis ossificans, excessive callus, residual stiffness, and decreased range of motion. So what I am going to give you is a technique which most of you must be using in your fresh cases also. But I just wanted to show you that this simple trick can be used in late presenting supracondylar fractures, and you can get away with all these problems. So this is the technique. This is late presenting supracondylar fracture. You can see the callus is there, and here you just manipulate it little bit gently in AP view, medial to lateral. Just break the callus slowly, and then you start reducing it. So here it is already medially displaced. Now you see here, make a small nick if you require. Make a small nick, and from here you put an artery and go from the fracture and go anteriorly to it. So, now see here, and you have to manipulate the medial and lateral. You have already reused in the AP, manipulated it, and then you are putting the artery inside and push the fracture, the distal fragment from the artery, and it goes anteriorly. If you see now, and see, you can see with this artery in Jones view also, if you take now, see, you will have, you see the Jones view in, again you can see AP and lateral, both, in both the views you have a good reduction. Now again, second case, this is again a late presenting supracondylar fracture, same trick applied, see, push the artery anteriorly, reduce it, and with the artery in situ, you can put K-wires, CAP view, and this is finally you get lateral view and view. So in this case, we need to keep the patients from hospital stays from 1 to 4 days because they are late presenting supracondylar fracture. We are scared about some vascular post-operative complications, neurovascular complications. Just for precautions, we keep them for 4 days. Plaster is kept for 3 to 4 weeks. Remove the plaster and allow them movement. After 7 days, the wires are removed. So this is again 18 days old injury with the callus, treated close. This is 4 weeks. Again another case, 15 days old injury, treated in same way with almost good accurate Bowman's angle, and there is no deformity. So to conclude, the cast immobilization and traction is not a safe method for late presenting supracondylar fracture, and operative treatment is the best option for the late presenting supracondylar fracture. Satisfactory results can be obtained using surgical treatment without mass ossificans, reduces chances of cosmetically objectionable varus deformity. Open reduction through mediolateral incision provide a better reduction, and then you can avoid the chances of stiffness. If you use a posterior incision to reduce this, when you are doing it open reduction, the chances of stiffness and adhesions are more. So if you need to open it, address both the pillars from one from medial side and one from lateral side, then the chances of stiffness and adhesions are less. This new technique is easy and reproducible and prevents the ugly deformity from malunion, no scarring, no stiffness, but larger studies and multicentric trials needs to establish this case. Thank you.
Thank you, sir, for your valuable tips on this very common problem, common presentation in our circumstances. Any questions? Daddy.
How much late can you operate? About 3 weeks old?
I've shown you it is as late as by 25 days. I'm trying for more cases, which I have done one case recently which was 5 weeks old, but in that case it was not exactly by this. This another, I just made an incision from the posterior side, and with a blunt osteotome I break the medial pillar and the lateral pillar, and then again use the same technique. And it was workable, but I don't have experience of more than 2 cases like that, but by up till 25 days you can do it. But you need to see that it has to be a little bit sticky, and you actually need to hold the distal fragment. Otherwise you may damage the anterior capsule. So you need to hold the distal fragment properly, and then at times if you feel that it is not easy, you can put a K-wire across the distal fragment and then hold and then try and manipulate, but not excessive movement. If you find that it is not workable, then you need to go for an open reduction.
Any difference of result when you are using one medial and one lateral pin, and another 2 lateral pin?
See, as per literature, it doesn't make any difference whether you use 2 lateral pins or 1 medial, 1 lateral, or 2 lateral, 1 medial. It depends on some situations. If you have a lateral condyle fracture separate, it's intercondylar, you may require two pins. But as per stability, yes, there is no much difference between 2. But of course, if you are scared of ulnar nerve, you can equally use lateral, but you need to have a difference of at least 8 mm between 2 wires, and they should be parallel. Certainly 3 K-bars are good, but if at all it is needed. You are going to put 3 K-bars only when you feel it. Otherwise 2 K-bars are sufficient.
In most of the cases 2 wires are sufficient, but in some cases you do require a 3rd wire. And about the angulation, I've been using this technique cases, up to 3 weeks, 20 days, 21 days, it works wonderfully. And the reduction, as it showed, it comes at simply. It comes at just put the hemostat and rotate the hemostat, the reduction and rotation, everything falls into place. Try it in 1 or 2 cases and you will cover it. Thank you so much.
Okay.
Mr. Jadhav.
Thank you.
Like Dr. Dhawan, excuse me as well for my bad throat. We are the organizers. And by the way, I hope you have enjoyed the IOACON 2013. Fracture capitulum. It constitutes 0.5 to 1% of all elbow injuries and 6% of distal humeral fractures. Mode of injury is either fall on outstretched hand or on the point of elbow. It is not seen below the age of 12 years. Similar injury in a child would cause a supracondylar fracture or a lateral condylar fracture. It is more common in women due to greater carrying angle and osteoporosis. The surgical anatomy, it is the first epiphyseal center of the elbow to ossify. It is directed distally and anteriorly, as Dr. Ram had shown, at 30 degrees to the sagittal axis of the humerus. The center of rotation is 12 to 15 millimeter anterior to the axis of humeral shaft. The lateral collateral ligament is attached to the lateral margin of the capitulum. The blood supply, it is supplied from the posterior aspect by the lateral arcade of the anastomosis around the elbow. There are various classifications given for these fractures. One classification is type 1, Hans-Steenthal type, commonest type with no involvement of the trochlea. Type 2 is the Cocker-Lawrence type. It involves shell of cartilage with minimal subchondral bone. And type 3 is Grantham, includes lateral part of trochlea, comminuted or unstable fractures. Bryan and Modi classification, Ring-Jupiter classification, and the latest classification, the Doublerley classification, came out in 2006. Type 1 is the primary capitular fracture with or without the lateral trochlear ridge. Type 2 is the capitular and trochlear fracture as one piece, and type 3 is the capitular and trochlear fracture as separate pieces. A without posterior condylar combination and B with posterior condylar combination. This is the commonly used classification nowadays. Type 1 fractures are caused by fall on outstretched hand. Fragment is displaced anteriorly and superiorly. Type 2 fracture is caused by fall on flexed elbow. Trochlear fracture is caused by fall on the olecranon. The clinical features: pain with minimal swelling and tenderness on the lateral aspect of the elbow. They are often missed fractures. Type 1 shows more limitation of flexion, while type 2 has more limitation of extension. Supination and pronation movements are painful and restricted. Investigations: plain X-ray, AP, lateral and external rotation views. The double arc sign of Mackey is important. It is an overlap of the subchondral bone of the displaced capitulum and lateral trochlear ridge. Radiograph the ipsilateral shoulder and wrist joints to exclude any concomitant injuries. The radial head capitular view given by Greenspan is sometimes required, specially useful to catch undisplaced fractures of capitulum, head of radius and coronoid. It is a modified lateral view. The tube is angled 45 degrees towards the radial head, projecting it ventrad. Unlike the lateral view, it clearly delineates the humero-ulnar and humero-radial articulations. Like we see here in the radial head capitular view, the fracture is very evident in the C picture. CT scan may be required in certain cases, especially in pediatric patients, to define the nature and pattern of the fracture and plan fixation accordingly. It may be associated with other injuries like the fracture of the head of radius, posterior dislocation of the elbow, disruption of the ulnar collateral ligament, ulnar nerve injury, disruption of the interosseous membrane and inferior radioulnar joint. Treatment options available are closed reduction and plaster immobilization. The most accepted treatment modality is open reduction and internal fixation. Excision of capitular fragment should be avoided as far as possible, and capitular prosthesis. Closed reduction and plaster, maintenance of reduction is very difficult, thereby leading to poor results. and even closed reduction may lead to avascular necrosis, probably due to the repeated manipulations to try and achieve an acceptable reduction. This is the most acceptable treatment of choice, especially with trochlear involvement. The surgical technique is simple. You use the Cocker's posterolateral J approach. This is the exposure. You reduce the fragment and fix it temporarily with a K-wire. A 3.5 or 4 mm partially threaded cancellous screw with washer is passed from the posterior to the anterior and fracture fixed under compression. Herbert screws, Accutrack screws, headless screws, biodegradable wires, maxillofacial plates have been used by different people. Herbert screw is the preferred modality of fixation. It can be supplemented with K-wires if needed. Resection of the fragment is indicated for small unfixable osteofragments only, specially contraindicated in trochlear fractures because it will lead to lateral instability. Arthroscopic excision is obviously less traumatic. Prostheses have been developed for the capital fractures as well. Jacobson in 1957 developed an alloy prosthesis with not very encouraging results, but Coney and Mori in 2006 published their results on radial capital prosthesis, the uni elbow. It is not yet available in India. The prognosis, if left untreated, causes impingement and restriction of motion and degenerative arthritis. Excision of large fragment causes instability and later loss of movements. Best results are achieved by open reduction and rigid internal fixation and early mobilization as in other intra-articular fractures. The complications can be stiffness. Open reduction and internal fixation has least incidence of stiffness. Instability seen after resection, especially of the trochlear fractures. Avascular necrosis is very uncommon, less than 10% even after open reduction and internal fixation. Malunion and non-union leads to stiffness and pain. Heterotropic ossification occurs in 4% of the cases of open reduction. These are some of our cases. I'll skip this. This is fixed with a single screw from posterior to anterior. The clinical results. The second case. Nowadays we use Herbert screws more. Another case. This is a type 4 fracture, a bad fracture, fixed with a Herbert screw and additional K-wires to supplement. Another case, a large fragment, Herbert screw and K-wires. Only small, I may conclude, only small osteochondral and unfixable fragments should be excised. Larger fixable fragments should be fixed by 3.5 or 4 mm screws or Herbert screws. The seemingly potential complication of AVN should be ignored and all fixable fragments should be fixed. Thank you very much. Any questions, please? We are running late. I think we start the next. We move on to the hall A for the valedictory function. Thank you very much.
Right. Good afternoon, friends. Sorry for all this, but I think so we have to make a start. I'm going to talk to you about all polytibial design of total knee replacement, early medium-term results in patients who are above the age of 70 years of age. No disclosures, no conflict of interest for this particular study. Various implant designs have been used in total knee replacement. The use of all polytibia is in practice since early 1970s. The first total condylar design that was ever put in 1974 was a total condylar all poly design. Early 80s saw introduction of modularity, that's a different metal base plate and a polyethylene insert. Now, because these are two different implants doing the same thing, we reviewed the literature. Clinical Orthopedic in 2000 showed a randomized comparison between all poly and the metal back tibia, and they showed no difference at 3 to 5 years. However, it was a short-term study. The same author again in 2010 reported at 10 years there is no difference between all polytibia and the metal back component. This was mid to long-term results. It had radiostereometric analysis and prospective randomized control trials. Further, JBJS in 2009, there was a direct comparison of all poly versus metal back tibial component, and at 10-year survivorship with aseptic loosening as the endpoint, the survivorship was 97% for all poly and 96.8% for the metal back. There was no significant difference between both of them, but both of them did very well with 96% or 97% survivorship. JBJS American 2011 cemented all poly versus metal back tibia. A meta-analysis showed no difference in the two groups in terms of functional status at 2, 8, and 10 years. Long-term results again, 91% survivorship at 23 years by Tom Skulko from Hospital of Special Surgery, 85% survivorship at 21 years in the hands of Dr. Ranawat, who was the original designer surgeon for this implant. So with this literature backdrop in our mind, we wanted to report early medium-term results of all polytibial component in elderly patients in our series. Inclusion criteria were physiological age above 70 years, low functional demand, good bone quality, exclusion criteria being inflammatory arthropathy, osteoporosis, poor bone quality, and high functional demand. 47 cases done between 2005 and 7. All cases were performed by myself using standard mechanical jigs or navigation. PS, all polytibial components cemented with CMW1 gentamicin mixed cement. Pre-op bone mineral density DEXA scan was not performed. All the cases were that of osteoarthritis. Routine post-operative protocol of weight-bearing mobilization started from the first day post-op. Of the 47, 3 were lost to follow-up, 7 diseased because of some medical conditions. 37 cases at the time of last follow-up were available, 28 female and 9 were male patients. Mean age index surgery 74, pre-op KSS of 47 improved to 87 at the latest follow-up. 34 cases were performing well functionally and clinically. Of 37 cases, there were 3 revisions, 2 for septic and 1 for periprosthetic fracture. There are no revisions for aseptic loosening or osteolysis in this cohort of 37 patients. 5 knees have a non-progressive radiolucent line beneath the tibial component. Some cases, a 78-year-old gentleman, bilateral total knees with bilateral total knees done, 5 years post-op. Another lady, 6 years post-op. These were done simultaneous. 72-year-old gentleman, 5 years post-op. 69-year-old lady, she had a failed high tibial osteotomy on one side and a failed hip because of an old tuberculous hip on the other side. So she had all poly on one side. Another 88-year-old gentleman, 7 years post-op x-rays. 91-year-old gentleman, 6 years post-op. 74-year-old lady, 5 years post-op x-rays. Now these patients also, depending on their functional demand, they can perform high flexion activities. So this again proves the point that high flexion or the flexion post-operative that one gets depends on the pre-op flexion. Obviously what we do surgically also matters, what soft tissue release and how bone cuts we've made, but even with a fixed bearing implant like all poly, if the patient is able to do this, they sometimes do in our social and religious setup. Failures, we had 2 dip sepsis. Both these patients had swollen knee, discharging sinus, and they were operated. I would come back to that again, why most probably these 2 patients have failed. These are their x-rays, post-op loosening, and they were revised. Metal back tibia has an undersurface, and undersurface wears from beneath the polyethylene of the tibia and the metal plate of the tibia. Highly polished trays are likely to eliminate this problem, but tibial load transfer is supposed to be uniform once we use a metal back tibia. This is the normal presumption. However, when we compared all poly versus modular implant in all these various aspects, we saw that undersurface wear, which is the main problem in the modular implant, is absent in all polytibial component. Tibial load transfer is uniform in both metal back or all poly. Polyethylene thickness for identical resection is more in all polytibial component because it does not have to accommodate for the metal plate. Intra-op flexibility is the only point where all poly does not score high. Liner dissociation is absent in all polytubule component, and obviously cost is cheaper in all polytubule component. However, there are some disadvantages of all polytibia. Lack of modularity, it limits the intra-op options, that you cannot attach the stems, augments, etc. There is no option of liner removal and debridement and washout in case of acute post-op infection. Perhaps this was the cause where we had 2 of our cases who had infection. They were opened for a washout, but obviously the poly was not removed, being a non-modular component. So this is the only disadvantage that I can think of all polytubule component. And late liner exchange cannot be done in case of minor instability of the poly. Optimum poly thickness is 8 millimeter to avoid excessive peak stresses within the liner. When we have all poly, the amount of polyethylene that goes inside is more for the identical resection. So if we are able to put 10 millimeter of all polytibia, that's all that you get the polyethylene into. But when you put a 10 modular knee, you have 8 millimeters of polyethylene inside, or maybe a little less. So for the identical resection, we have more poly in all polytibial design. Reduced poly thickness risks the failure of wear through the metal on metal. This particular publication from Dr. Anawat, all polytibial component may be appropriate for younger and active patients. Excellent long-term clinical and radiographic results in younger patients of less than 65 years of age. Operative steps: perfect tibial cut, lateralization of femoral and tibial components, perfect gap balancing, because there is no chance to change the polyliner once the cementing is happened, and thin layer of cement normally put at the back of the tibial cut surface. Elderly, low demand patients generate lesser stresses on the articulation, reduces the incidence of premature wear and osteolysis. Perfect surgical technique is mandatory. So in conclusion, our series shows no revisions at early medium term, that is 5 to 7 years, for aseptic loosening. An excellent clinical result in this cohort of patients supports the continued use of this implant. For a cost-conscious health system such as ours, the savings in the implant cost is significant. I thank you for your attention. Yes, please. Yeah.
Any specific reason why you have selected only patients of 70+ age groups for your all-poly?
Correct. Now, if you see that particular publication from Dr. Anawat, he has mentioned the cutoff being 65 years of age. Patients less than 65 years of age, if we do all poly, the results are not very satisfactory. That's what Dr. Anawat mentioned. So cutoff is 65 in his hands. 70 is because we want patients who are physiologically above the age of 70. They have lower stresses. They are more or less retired from their active functional life. So the stresses that it will generate on the implant and articulation will be much less. So we wanted to examine all poly as an implant. How does it do? We know that if given higher stresses in younger patients, it may fail. So that's the reason we put it in elderly patients, because they generate less stress.
One more question, please.
Yeah, sure.
Yeah. Do you think that banging upon the poly during cementation is acceptable or justifiable?
Banging.
Yeah.
I
Because
mean,
in a metal-backed tibia, it's a different scenario.
Sure.
You'll be banging on the metal.
Correct.
And
Correct.
putting on the
Right.
again liner again.
Yeah, I mean, that can be a problem, but just banging, those 3 or 4 taps, I don't think so is going to damage the polyethylene. No, that's not going to happen. What can happen though is when you are banging it in, sometimes the cement can have fretting. With each banging, the processes will go down little bit. So the cement will not, it will have sort of small waves, as you give more and more bangs. Instead, if you are able to put the cement on the proximal tibia and just with your hand in one movement, just try and insert the prosthesis till the time it touches the bone, and then just give one final tap. That's what I do.
But does it produce some sort of a surface lamination type or small micro cracks
On
in
the
that
polyethylene?
poly? Yeah.
No. It does not.
On the upper surface?
No, it does not. It does not, because though you have those silastic punches, so just put on that and give a gentle tap. It does not produce any lamination, because the way in which the polys are manufactured now is a lot different than what it used to happen 30 years ago. I mean, that's why we even sometimes put this in rheumatoid patients, because rheumatoid, the problem is osteopenia and osteoporosis. We are worried that the stress dissipation will happen properly or not. Using the modern all poly, the lower part of the polyethylene is so sturdily built, and when the pressure starts from above, the lower part of the polyethylene really almost offers like a metal. Though it's a plastic, but it is so sturdily built that it almost offers the stress resistance like a metal. So even putting in rheumatoid is not a problem. Though I personally have not done in this series, but people have done it.
Thank you.
Okay. Any more? Right. Thank you very much. So next gentleman. Sorry, the latecomers. We have no chairman, so we are the speakers who are just finishing all the talks. Dr. Chaudhary, I think so, is next. You carry on. Yeah. Thank you.
A very good afternoon to all of you. I am Dr. Siddharth Chaudhary, and my topic of presentation today is direct comparison of pharmacokinetics and pharmacodynamics of apixaban and rivaroxaban. So this topic is little bit different from the surgical intervention, and it's about anticoagulants. Just to give you the background, apixaban and rivaroxaban are oral direct factor 10A inhibitors which have shown promising results as anticoagulant drugs for several indications. And in India, both apixaban and rivaroxaban are approved for venous thromboembolism prevention in patients undergoing THR and TKR surgeries. The approved regimen is apixaban 2.5 mg twice daily, whereas rivaroxaban 10 mg OD is approved. Although a general relationship between exposure and efficacy and safety of direct factor 10A inhibitors have been observed, but the key pharmacokinetic and pharmacodynamic parameters driving this relationship has not been identified clearly. So this study was aimed at developing a better understanding of the pharmacokinetic and pharmacodynamics profiles of each agent. The objective was to assess the multiple dose, steady state, PK profiles of apixaban and rivaroxaban following oral administration in healthy subjects. Second objective was to compare the plasma concentration peak to trough, that is maximum to minimum concentration of these drugs. Third one is to assess the multiple dose steady state pharmacodynamic profiles, that is anti-factor 10A activity of apixaban and rivaroxaban. And the last objective is to assess the safety profile of these drugs. So this is the design of this trial. It was a phase 1 randomized, open label, 2 period, 2 treatment crossover study on eligible healthy subjects. So these subjects, after screening, were randomized to one of the arm, and they received 4-day treatment with either apixaban 2.5 mg BD or rivaroxaban OD. Followed by the period 1, there was a washout period of 5 days. And then during the period 2, there was a switchover of treatments. So the subjects who received apixaban during period 1, they received rivaroxaban during period 2, and the subjects who received rivaroxaban during period 1, they received apixaban during period 2. And the blood samples were collected to assess the pharmacokinetic and pharmacodynamic profile of these drugs, pre-dose on day 1 and day 2, and thereafter 72 hours after the dosing after day 4. Coming to the results here, this graph shows the mean plasma concentration over time after treatment. So here on the left side you can see on the x-axis time in hours, on the y-axis you can see the plasma concentration of these drugs. The red line denotes apixaban, whereas the blue line denotes rivaroxaban. So here we can see that it's not working. So here we can see the maximum plasma concentration after giving the dose is high with rivaroxaban, whereas the trough concentration, that is the minimum plasma concentration after 24 hours, was low with rivaroxaban as compared to apixaban twice daily regimen. And when we And when we take the geometric mean to trough ratio, that is the maximum to minimum plasma concentration, it was 3.6 times higher for rivaroxaban as compared to apixaban. That shows that this plasma concentration variability is less with apixaban BID regimen as compared to rivaroxaban OD regimen. And also the variability is high with rivaroxaban as compared to apixaban. Coming to the pharmacodynamic results here, again on x-axis time in hours, whereas in y-axis anti-factor 10A activity. Here you can see again with the anti-factor 10A activity is very high with rivaroxaban after giving the dose, whereas when you look at the trough value of this anti-factor 10A activity with rivaroxaban, it was very low. So again this consistent effect was seen with apixaban BD regimen as compared to rivaroxaban OD regimen, and the variability with rivaroxaban was high as compared to apixaban BID regimen. Safety endpoints all were assessed by closely monitoring adverse events. Total 22 adverse events were reported, and all these adverse events were mild in intensity like contusions, epistaxis, dizziness and so on, and there were no deaths or serious adverse events were reported in this study. So to conclude, dosing with apixaban 2.5 mg twice daily resulted in significantly lower peak to trough fluctuation in plasma concentration and less fluctuation in anti-factor 10A activity throughout the dosing interval compared with rivaroxaban 10 mg OD regimen. Apixaban 2.5 mg BID resulted in less inter-individual variability across all pharmacokinetic and pharmacodynamic exposure parameters as compared to rivaroxaban. PK findings were similar with that of the previously reported studies, and all the safety findings were equal in both the arms, and there were no serious adverse event reported. That's it. Thank you.
This is only for hip and knee replacement, or even in fracture neck of femur, the old patients who are gone, bedridden patients also required to use?
Yeah. So currently in orthopedic surgery, rivaroxaban and apixaban both are studied only in patients undergoing THR and TKR, not in other hip or say hip fracture surgeries or any other surgeries. So currently we have data only in THR and TKR surgeries.
Why would it be like that? Just want to understand the methodology of the study.
Because if you look at the endo study, so they have studied what are the incidence of DVT or pulmonary embolism depending on the surgeries. So it was found that the incidence of DVT and PE, it is around 40 to 60% in patients undergoing THR and TKR surgeries. Okay, so that's why to test this anticoagulation effect, these populations were selected first. But in the USA and Europe, apixaban, it has been approved for stroke prevention also and atrial fibrillation for various other indications. But currently in India, it is approved only for VTEP in THR and TKR.
Any fatal complications of the usage of rivaroxaban?
Sir, in this study particularly, there were no side effects, serious side effects, because this objective of this study is very simple, to study the differences in the pharmacokinetic and pharmacodynamic parameters. But if you're talking about phase 3 trials, like record trials, definitely with anticoagulation, bleeding is a risk. So rather than going into the details of phase 3 trials, I will just stick to this PK/PD profile. So objective was to see how it differs. So it is not differing very much with apixaban 2.5 mg BD regimen as compared to rivaroxaban OD regimen. Yeah.
Even after this towards these medicines, if someone develops DVT or PE, then should we switch to no molecular hepatitis or should we continue with therapy?
Yeah. So the question is that if somebody, if the patient is receiving apixaban for venous thromboembolism prophylaxis, but if that patient develops DVT, then what happens? Okay, so these drugs are mainly for DVT prophylaxis after THR and TKR. So if the patient develops DVT, then that is the case of DVT itself. So you should treat the patient like the normal protocol. So definitely the normal protocol is to use heparin first or lower molecular heparin first and then combine with warfarin. Because currently these drugs are not approved for DVT treatment, although the data is published. But in India, currently it is not approved for DVT treatment. So you should consider that patient as the DVT case and treat like the normal protocol.
Will there be any gap
Yeah, so first of all, we don't have any clinical data from switching to apixaban to enoxaparin. But based on the pharmacokinetic profile, these drugs have got very short T-half. So if you look at the T-half of apixaban, based on this study, it is around 8.7 hours. So if you can wait for 2 T-halves, then only 25% of the drug would be there in the plasma. Okay, so you can, based on your judgment, you can switch after 24 hours. And looking at the patient benefit risk ratio, if the patient is at the high risk of bleeding, then you may want to wait for more time.
I would like to add only just one point to this issue because of the speaker. One question has come from that
Yes.
side.
Yes, sir.
I had a very bitter experience 7 years back in 2006, if I am correct. I did a cemented total hip.
Yes.
And the patient was around 64-year-old male patient, and he is a diabetic case.
Okay.
And I kept that patient 2 days prior on enoxaparin.
Okay.
And the patient was absolutely fine up to 5 days. And I was about to discharge him. And that guy developed all sorts of irrelevant talk, nasty behavior, throwing out himself like that. So ultimately, when we investigated the case, when we did a CT angio, it came up to a big pulmonary thrombus, big at the level of bifurcation.
Yeah.
So what I mean to tell the audience is, there is no guarantee that simple usage of low molecular weight, any sort of heparin, might be bemiparin, whatever, enoxaparin, whatever may be the thing, there is no guarantee that the patient will not develop either DVT or PE. It only reduces the risk of complication. It will not prevent. You have to take it granted the word. It only reduces the risk, but it will no LMWH as of now available as any evidence-based data to say that they will definitely prevent either DVT or developing PE. That's it.
Yeah. But looking at the data of these NOACs, these drugs are potent as compared to enoxaparin. It was proved in various phase 3 clinical trials that efficacy-wise, both apixaban and rivaroxaban, they are potent, and the primary efficacy endpoint were significantly low with these drugs as compared to enoxaparin. But to definitely look at the PE, you need the very large sample size, and as mentioned by you, but all these DVT incidences were low with this NOACs. That's it.
How long to continue and how to switch off the, should we really gradually or should we monitor anything?
Switch from enoxaparin to this drug, or
Suppose the patient is on prophylactically on apixaban or rivaroxaban
yeah.
and the THR or TCR was performed, and when to stop it?
Okay. Yes.
How to stop it?
Yeah. So according to recommendations, as per the AOS guidelines, latest guidelines, they are recommending to use these anticoagulant drugs at least for 10 to 14 days in both THR and TKR patients. In case of THR, they are recommending up to 6 weeks. So if you look at this phase 3 clinical trials which were conducted in these oral anticoagulants, for TKR, they had used the drug for 10 to 14 days. And for THR, they had used the drug for 32 to 38 days. I think this duration is fine enough.
Do we need monitor pre-op or after post-op?
Yeah, very good question. According to European regimen, enoxaparin was started pre-operatively. Okay. Enoxaparin I am talking about. 12 hours before enoxaparin. This is the recommendations by European guidelines. But if you look at these drugs, apixaban, rivaroxaban, these drugs are started post-operatively. So apixaban was given in advanced trials, in these phase 3 trials. It was given 12 to 24 hours after surgery, whereas rivaroxaban was given 6 to 10 hours after surgery.
Do we need to monitor anything?
The good part of these drugs is there is no requirement of any monitoring. Consistent effect is there, no INR monitoring is required, no PT monitoring, no PTT monitoring, nothing.
We can suddenly stop the drug after 14 days or 6 days.
Yes, yes, you can just stop the video. No problem. Okay. Thank you. Thank you very much for this highly high-level interaction. Thank you. Thank you.
Good afternoon, my teachers, colleagues. Today, I am going to present upon acetabular cup placement in total hip arthroplasty, how to be accurate. Total hip arthroplasty has become a very frequently performed procedure nowadays. And the most challenging part of performing total hip arthroplasty is accurate placement of acetabular cup. Acetabular cup malpositioning is a prime cause of dislocation after total hip arthroplasty. However, Argball et al. Revealed an extremely low dislocation rate of 0.6% with use of the transverse acetabular ligament as a reference aid in acetabular cup positioning. Improper cup placement is also recognized as a risk factor for impingement and increased wear after total hip arthroplasty, both of which may result in implant failure and many other complications. So the objective of our study to hypothesize that the technique of acetabular cup placement by using transverse acetabular ligament and posterior lip of acetabulum as a guide ensures more accurate result than the commonly used conventional technique of acetabular cup placement by using the direction of the inclination rod and version rod provided with the acetabular cuff holding jig. 34 cases of total hip arthroplasty was performed in our department. Out of them, 29 had fractured neck of femur and 5 had avascular necrosis of femoral head. And they are allocated into randomly into two groups, group A, that is the conventional technique, and group B, that is the technique by using transverse acetabular ligament and posterior lip. And the results are analyzed on the basis of preoperative and postoperative CT scan and X-rays. Although the expected safe zone of anteversion and inclination is 15 plus minus 10 degree and 40 plus minus 10 degree respectively, but we propose that the reproducing patient's own inclination and anteversion gives the best result. This is the perioperative photograph showing transverse acetabular ligament and posterior acetabular lip. Now from this table we can say that the proportion of both postoperative version and inclination within safe zone were higher in our treatment group as compared to conventional method. This is the master chart. And from group statistics, we can also comment that patients under our study group had less difference in pre and postoperative mean version and mean inclination than conventional treatment group. Now I'm showing some CT images of normal version and post-op version and normal inclination and post-op inclination in conventional technique. Another one. It's another. Now the CT images showing normal version and post-op version in our study group. Normal inclination, post-op inclination. This is another case. Case B9, normal version, post-op version, normal inclination, post-op inclination. Now to compare the accuracy between these two techniques, we put up two cases, and in conventional method, the preoperative version was 3.9 degree, and postoperatively it was 23.6 degree. So the difference was 19.7 degree. And in group B, that is in our method, the preoperative version was 7.2 degree, and the postoperative version was 9.6 degree. So the difference was 2.4 degree. Similarly, in case of inclination, in a conventional method, the preoperative inclination was 32.1 degree, and postoperatively it was 60.9 degree. So the difference was 28.8 degree. And in our study method, that the normal inclination was 42.7 degree and post-op inclination was 44.5 degree. So the difference was 1.8 degree. So from these slides, it is quite evident that by using transverse acetabular ligament and posterior lip of acetabulum, we can reproduce the values near normal to patient's own inclination and aversion. Now in our study, we found that 75% of patients of group A had postoperative version within the safe zone, whereas that was true for 95% of patients in group B. Similarly, the postoperative inclination was within safe zone in 69% of patients of group A and 89% of patients in group B. From the statistical analysis, we are coming across the fact that the group B is statistically more significant than group A. Therefore, we find that although both methods gives result more or less within the safe zone, but using transverse acetabular ligament, we can place acetabular cup more accurately. That is near normal to patient's own inclination and version. But there are certain literature indicating difficulties in identifying transverse acetabular ligament and posterior lip of acetabulum, particularly in cases of primary osteoarthritis of hip, where these structures may be obscured by osteophytes. However, Argbol et al. Originally claimed that it was seen in 99.7% cases, and also in case study of 114 cases, Mayasi et al. Were able to identify it in 81.6% cases. And the most common indication of total hip arthroplasty in our study population was fracture neck femur. No patients in the study population had primary osteoarthritis of hip. Hence, we had no difficulties in identifying transverse acetabular ligament and posterior lip of acetabulum intraoperatively. Moreover, due to unavailability of facilities of proper patient positioning, tilting of pelvis from true lateral position was quite common, and hence adversely affecting the acetabular cup placement by conventional method. So in conclusion, we can say that the method of acetabular cup placement by using transverse acetabular ligament and posterior lip of acetabulum is more accurate than conventional method when there is no problem in identifying these structures. Thank you. Is there any question?
It's not a question actually, but I would like to just pass on a comment upon your lecture. One point you have stated that it will always work correctly if you conform the cup to the native anatomic acetabulum. But that's not true in each and every case, because in a few number of cases, which I have personally experienced, the native acetabulum will be in a little bit of retroversion. When you confine your cup to the specific margins of the posterior lip as well as the tal, you are definitely going to put your cup in a retroverted position. So what I suggest is that to carefully evaluate the pre-op x-rays to look for the signs of retroversion in the x-rays, or else go for CT scans. I look specifically for the crossover sign, both for the anterior and posterior margins of acetabulum. If there is a crossover sign, it indicates that the acetabulum, native acetabulum, is in retroversion. Then you have to voluntarily keep your cup in the anteverted position. So in such a case, conforming the cup to the native margins of the acetabulum is not going to work.
Exactly. In our department, we generally done the pre-operative CT scan, and then we decide and the cases are allocated randomly, that if there is any degenerative disease or something, or there is retroversion, we go for conventional method.
Suppose we place the using not using the conventional method, by using the tab and posterior, and if that is somewhat retroverted, beyond 40 degrees, apart from the range you have mentioned, plus minus, then how to, we have brain and we have to place the acetabulum, then how to manage the antiversion, what measures can be taken?
If preoperatively we get that the cup is retroverted, then we'll go for conventional method.
It can happen during surgery, that somewhat template doesn't, we cannot go with the template always, but somehow it is somewhat bit misplaced. So how can we come on that situation?
Then you have to go for
If we retract both the structures, we are not going to put the place 100% situations. We are not going to put the axillary cup in the same degree.
if you don't judge the version of the cup preoperatively, then it is quite impossible to judge perioperatively.
If you, excuse me, may I answer that question, please? Yeah. You mean to say that if you have you cemented the cup in a retroverted position, how is that you are going to correct it? Am I right? That's your question, no? There are specific stems in specific companies wherein they give altered antiversion retroversion grades. Not all companies will provide that. Wherein, yeah, you can adjust that with the stem. According to the
femoral
geometry of the
anteversion.
retroverted cup. Yeah, what can you do after that, cementing the cup? There is no way bailing out. So the only way to tackle that problem is to have a differential anteversion, retroversion necks you have in certain companies. They do provide that. So you have the option in such a case, not in all companies.
Either method we can go with the aspirator, but intraoperatively we have to place
Yeah,
correct.
yeah, that's it.
Our target was the total version is femoral version plus acetabular cup version is 40 degree. So if there is any problem that more than 25 degree, then sir said that we can adjust by femoral version.
It's only a bailout option. It's not the perfect, remedy or solution for that. It's only a bailout. Somehow to get out of the procedure. Somehow you have to get out of the OT room. So it's only a bailout thing. It's not the perfect solution for that. The stem during different range of motions will not dislocate. But that particular patient might not have the complete range of motion. It's a bailout option.
My second question is that you have mentioned this, suppose in a oncologist, so what we are going to do?
In a study of 1,000 cases, Archbold graded the transverse acetabular, how we can identify the transverse acetabular ligament. There was 4 grading system, and in case of grade 4, like in any degenerative condition, we cannot identify transverse acetabular ligament intraoperatively. So up to grade 2, it is we can make it easily, but in grade 3 we have to ream the acetabular cup. We have to ream the acetabular cup more carefully.